Thank you for giving me the opportunity to speak on innovative intraoperative techniques to reduce margin positivity and subsequent adjuvant treatment during robotic radical prostatectomy. My talk will cover the problem statement and innovations in the field and impact of those innovations on the outcomes. Radical prostatectomy carries the potential to impact the lives of patients significantly and irreversibly. And the true NTH post surgery UK investigators remind this to us with their periodic analysis, latest of which from 2024, from 26 UK centers, including 2,000 men operated between 2015 and 19, shows that among men who were leak free and pad free at baseline, 1 in 3 reported wearing a pad at 12 months, and 1 in 10 reported a moderate or big problem with urine leakage. Among men with strong erections at baseline, at 12 months, only 6% reported erections sufficient for intercourse without a medication. 4 out of 5 men needed more than tablets and a vacuum pump when it came to keeping sexual function alive. During the same time, Bau's audit shows that while half of patients should have been eligible for a full bilateral nerve spare, only a third ultimately got it. And despite overtreatment and over resection, 1 in 5 still ended up with a positive margin. Thus, there is a huge unmet need for better aid to intra-op decision making to save the nerves and preserve potency and continence mechanisms better. And we have innovated and tried to come up with solutions intraoperatively, which can be broadly classified into ex vivo and in vivo categories. In an ex vivo technique, we essentially extract the specimen to immediately assess its margins. The most popular among the ex vivo techniques is the Neurosafe technique, which is based on the same principle of frozen section analysis, which is the standard of care for many other cancers as well. The main issues impacting its widespread adoption include the need for a dedicated uropathologist, added 1 hour of processing and analysis time, and the involved costs. However, newer ex vivo techniques using confocal laser endomicroscopy that is being currently trialed at Imperial allows you to immediately process the whole mount specimen for margins bedside in 10 minutes, and the images can be interpreted with aid of AI and a remote pathologist, with the learning curve being not prohibitive for a surgeon to also master. Their initial results of the Imperial Prostate Flores trial, announced in EAU 2025, show a high positive and negative predictive value reaching 80% for any margin. Techniques involving ex vivo imaging based on PSMA PET that we hope to trial in future at Portsmouth allow you to completely bypass the pathologist, but then brings the nuclear medicine specialist into the theater to give the PSMA bound ligand in the morning prior to the operation. Intra-op PSMA scanner can show surprise new lesions that Neurosafe may not even suspect. So, for example, this case had lesion in the left lobe of the prostate on preoperative MRI, right lobe on the preoperative PSMA PET, but intraoperative PSMA PET showed a new third anterior apical lesion that was positive at the margin. Dar et al. Recently reported in EAU 2025 that in their cohort of 28 patients with high-risk cancer, 40 to 70% of patients, which could have had both or one side nerves at least spared based on intra-op PET assessment of margins. However, a common issue with all the ex vivo techniques is that it's difficult to orient the margin positivity spot to the exact corresponding area of the neurovascular bundle, and we end up resecting the whole neurovascular bundle if the margin is positive. However, we can solve this challenge with an in vivo technique, and MRI combined with live augmented reality using the Tile Pro feature of the Da Vinci has been an area of active interest since past few years, and so have been 3D printed models of prostate to help surgeons better understand spatial orientation of lesions during dissection. Meta-analysis of small number of series show a trend towards better attainment of negative margins and higher potency and continence at 12 months using augmented reality models. We can also perform confocal laser endomicroscopy intraop using fluorescein injection and a fiber optic probe, though it does add to time and responsibility on the shoulder of surgeon. However, I find in vivo technique relying on fluorescent probes and PSMA guided near infrared fluorescence to be the most appealing, as it allows the ability to pinpoint the exact location of the neurovascular bundle where cancer cells are. And then we can do a limited resection of the neurovascular bundle limited to that area. These innovations have now stood the test of a phase 3 randomized control trial and Neurosafe Proof trial randomized 400 patients split into Neurosafe and conventional RALP arms across multiple UK centers with inclusion criteria of men with strong erections at baseline, with IIEF 5 score at 12 months being the primary outcome of interest. Despite the surgery planning MDT recommending a bilateral nerve spare in only a third of patients preoperatively, 82% patients had a full bilateral nerve spare in the Neurosafe arm, and extensive or multifocal margin positivity was no different across both treatment groups. However, patient in the Neurosafe group had the opportunity for additional intraoperative resection for a positive margin, which was done in 17% cases, and cancer was found in the additionally resected tissue in 44% cases, justifying the decision. And as far as for the principal outcome, while 20% in the conventional RAL had mild or no erectile dysfunction at 12 months, this figure in the Neurosafe arm was 40%. So data on Neurosafe has now reached substantial numbers to draw some reasonable conclusions. It does seem reliably associated with better potency rates while allowing for a lower rate of positive surgical margin with no harm in terms of biochemical recurrence rates, at least in the short term. And there is no evidence to believe that long-term outcomes would be any different. So in conclusion, intraoperative margin assessment allows better preservation of potency while not compromising on any oncological outcomes, and in my humble opinion, should be the standard of care in institutes of excellence. Thank you for your kind listening.